Hey everybody, David Levine here. I'm one of the orthopedic surgeons on the foot and ankle service here at Hospital for Special Surgery, and we're going to go forward and make a video about the foot and ankle examination. So welcome. I wanted to thank our patient model for agreeing to be a part of this video. So we're going to give you perspective on how we approach the exam of the foot and ankle. Remember that the foot and ankle is the larger part of the entire weight-bearing structure of the skeleton. So from that perspective, I typically will start an examination by asking our patient with both feet without shoes or socks to just simply stand. So if you please would just stand. The purpose of this part of the examination is just to recognize again that the ankle and foot is part of the weight-bearing extremity. So it's an issue of really just checking alignment at this point. So I want to see if there's valgus or varus of the heel, or whether or not there's out-toeing or in-toeing or any kind of rotational deformity. We can see if the knees are knock-kneed in genu valgum, or if the person is bow-legged, or if they have an obvious leg length discrepancy. These things are only going to be observed if you ask a patient to stand. And of course, as always, the patient may be here for one-sided problem, but it's always appropriate to check their opposite side as their mirror image. Now that we've evaluated our patient from the front, we're going to ask her to turn around. And this way we can observe the heel alignment, whether or not there's valgus or varus, whether or not there's a tilt of the pelvis because perhaps there's a leg length discrepancy. Again, one gets to see whether the knees and the leg from hips to knees to ankles to feet are aligned or malaligned. The next maneuver, which is important, is to ask the patient to do a double limb heel rise. So before we do that, I'm going to just ask the patient to walk a little bit closer to the table, and I'm going to ask her to put her fingertips on the chair or table just for balance purposes, but not to bear weight. And I'm going to ask her to go up on her tiptoes. And notice that as she does so, both of her heels invert, and there's a maintenance of one's arch, and it becomes very visual. They're symmetric, which is important. And now I'm going to ask her to come back down, thank you. And I'm going to ask you to take one of your legs off of the ground. Perfect. And again, just reminding you to use your fingertips for balance only. Go up on the tiptoes of your remaining foot. And that is called a single limb heel rise. And again, we're seeing that the heel inverts and the arch is accentuated. And this is the most provocative maneuver to test the integrity of the posterior tibial tendon, which is something that is very important in flat foot problems and in many of our patients that come to see us. So thank you. You can go back down. Now, place your right foot back on the ground and take your left foot off the ground, and let's repeat. Got it. So again, we see that the heel inverts, the arch is accentuated and maintained, and that's very healthy. So you can come on back down, but stay facing that direction. I just want to emphasize that patients often will want to perform well during their examination. So if a patient cannot do a single limb heel rise because they have a problem with their posterior tibial tendon, they often will start to lean on their table a little bit more with their hands and let their hands help bear their body's weight. So you often have to remind them, if it seems as though they're doing that, to just use their fingertips for balance purposes only. If they can't do it, that's what we want to know. We don't want them to succeed because they're cheating in essence. So now that we have our patient seated, we're going to go through an organized exam, and typically I'll start with pulses just to make sure that all is well from a vascular perspective. So just casually we'll grab the foot, and I'm going to feel first on the dorsum of the midfoot for the dorsalis pedis pulse, and that's a nice present pulse, it's regular. And then I'm going to feel along the posterior medial aspect of the ankle for the tibialis pulse, and that's appropriate as well. The next part of the exam classically is going to be an evaluation of sensation. In essence, there are 5 distributions of a foot in terms of peripheral nerves in the level of the foot. The dorsum of the first web space, the deep perineal nerve. I'm going to ask the patient whether or not this feels natural, or this feels fuzzy, tingly, zingy, or absent on occasion, or hypersensitive. Going to touch the dorsum of the foot other than the first web space, which is the superficial perineal nerve distribution. Going to touch along the outer border of the foot, and that is the sural nerve distribution. On the inner border of the ankle and foot, the saphenous distribution. And then finally, plantar medial and plantar lateral branches of the tibial nerve. So those distributions. The next component of the examination is palpation, the actual touching of the foot and trying to look for either tender spots or areas that are bony prominences, perhaps causing pain just from rubbing against shoe wear. So I'm going to note the prominence of the lateral malleolus and to note whether or not it's tender to examination. Can feel along the posterior lateral border of the ankle and feel the peroneal tendons and determine whether or not they are reduced or properly seated behind the fibula, or whether or not they're in front and subluxated. We can follow our way down to the base of the fifth metatarsal, which is characteristically a bony prominence in most people, but you may want to again examine the opposite side and to see if it's more prominent, perhaps as a consequence of an old fracture. The heel, it's an opportunity to gently grab the heel and determine if there's any tenderness there. One can palpate for any kind of bony prominence at the insertion of the Achilles tendon, as is commonly seen in a Hageland's deformity. One can walk towards the forefoot at the MTP joints and again either look for a prominence of a bursa or tenderness. Evaluate the presence or absence of pain or deformity by just simply doing a quick maneuver of each toe and a quick maneuver for palpation and for tenderness as well. And then finally, range of motion, as we talked about it before. And then I think as well, palpation across the midfoot to determine if there's any bony palpable tenderness, or specifically, oftentimes a patient may have an arthritic spur or a dorsal boss on the top of the metatarsals. One maneuver I think that's particularly important in assessing that, if the person does have pain on the top, would be to do exams where you do a sagittal stress, where you can move what you believe to be a painful joint and exacerbate that stress by sagittal plane motion and determining if that causes an exacerbation of their complaints. More towards the inner border of the foot, so I'm going to switch feet to just do a better illustration of that. One will palpate along the posterior tibialis tendon down to the navicular insertion, and in persons with an accessory navicular, that could potentially be tender. That may be why they're coming to see you. You can palpate the medial malleolus and move towards the inner gutter of the ankle joint. And then one can walk down towards the midfoot and assess Lisfranc's region, the midfoot. And of course, if there's prominence along a hallux valgus or a hallux rigidus in terms of bony overgrowth, one can see this as well. Finally, palpation along the plantar surface of the foot is a useful assessment for patients who come complaining of heel pain and an assessment of plantar fasciitis. Gentle extension of the lesser toes and the hallux. You can often feel the prominence of the plantar fascia beneath the foot, and you can walk back towards its origin along the plantar and medial aspect of the calcaneus. Palpable tenderness in this position, often consistent with plantar fasciitis. The next part of the examination, we're going to do some gentle strength testing. So I'll typically start and ask our patient to curl around my finger and check plantar flexion. We can isolate a big toe, curl down against my finger, so checking the FHL. I typically bring my finger on the top of the foot and ask if you pull your toes up towards your nose, and you're checking both EHL if you just isolate the great toe, so do that please, great. And then the lesser toes, so do that as well. And then I'll characteristically ask the patient to just bring the entire ankle upwards towards your nose, if you will, checking dorsiflexion. Perfect. And now I'll typically ask the patient to do inversion, and then I'll ask for eversion. Come back to the neutral and plantar Great. And I think the coordination of dorsi and plantar flexion, inversion and eversion, we tend to call circumduction. So gently make a big rounded circle for me. Perfect. And if you do that in an opposite direction, perfect. Great. So now we're going to move on to strength testing. With respect to strength testing, it's really those same movements, but now just applying resistance. So if I want to make sure that toe extension is 5/5, I'll ask her to pull and resist me. Great job. And I'll ask her to push against me. Perfect. I can put my hand on the inner border of the foot and say invert against me. I think a word of caution here. Patients, again, often want to perform and achieve success. So sometimes a patient will use their hip adduction and try to move their whole leg inward against me, or sometimes they may actually try to like rotate their leg in. But what you're really looking for in the foot and ankle exam is true inversion of the hind foot, and that's the movement you see now. So relax that and show me again that you can push inward. Great. And the same thing really goes for eversion. I'm going to ask her to relax for a moment so I can start her from an inverted position and say, now evert against me, and push, 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 keep on going. Now you're checking the eversion function. I'll put my hand on the top of the foot and again say dorsiflex, please, pull upwards towards your nose. Great. And finally, while it's up there, give me a good, strong push. And recognize that in most circumstances, a patient's muscles of their leg should be stronger than muscles of fingers or a hand, right? It's much more powerful. So ideally, a person should be able to overpower the average examiner's hand. The next move, we've just really assessed, even in the process of doing some strength testing, and you can relax your quad. I know patients often want to hold up their leg, but just let it fall into my hand. We've seen motion in the process of doing some resistance and some strength testing. But now I want to do motion passively. I want to check a sense of the patient's range of motion on my own. So as an example, we often will frequently see a patient come in with a complaint of great toe arthritis or great toe pain, and we're interested in range of motion. So I'm going to typically take the lesser toes, and I'm going to try to dorsiflex them myself, passively, meaning I'm doing it, the patient's not. I'm doing it gently, so I'm not going to hurt her if she has some kind of condition, but I want to get a sense of how much dorsiflexion the patient has at the lesser toes. And then I can compare that to dorsiflexion of the great toe. I can ask her to do it actively, so bring your big toe up as far as you can, and now relax it. And I can do passive motion. And again, this is a great time to emphasize that I don't know whether her motion is too loose, too tight, or that's her. So let's check the opposite side. So whether a patient has hallux rigidus and stiffness that's pathologic, or they happen to just be a tight, inelastic person, you can tell by examining side to side, and that's an important part of what we do. So the next maneuver that I'd like to do is now move towards certain more provocative maneuvers that tend to be more specific towards certain disease conditions. So for example, if a person is coming in because they've had an ankle sprain or an ankle injury or complaining of ankle instability, we want to do the drawer and the tilt testing of their ankle. And so classically, the first thing that you need to do is ask the patient just to remind them to relax. So you want their quad to be relaxed. You want to allow their knee to just gently flex passively, so they just want to relax their leg, because if they're firing their quads or they're firing their gastroc and calf muscle, that tension will often overpower the ability to sense subtlety of instability. So she's very relaxed right now, her quad is relaxed, her knee is flexed, so it relaxes the calf, and I'll grab my outer hand towards the back of the heel and around, and I'll stabilize with my other hand. And again, with a little bit of plantar flexion and a relaxed ankle, I will then pull or try to draw her foot towards me. And this is checking the anterior talofibular ligament, which is a common source of injury or site of injury following ankle sprain. I also then can use my same stabilizing hand and take the position of the same and then try to invert her in a varus kind of a fashion, which is checking the calcaneus fibular ligament, the second ligament often injured in an ankle sprain. And in this case, she seems stable in both tilt as well as drawer. So again, what do? I don't rest on the laurels that that's normal. What if her other side is even tighter? Or what if it's looser? So this is a perfect circumstance where one wants to examine the opposite side. So again, I'll ask you to relax your quad and let the knee kind of be loose and relaxed. I'll put my hand down and I will give a drawer and I will give a tilt. And that's a way to compare side to side. While I'm on the left leg, I think it'd be appropriate to start talking about evaluating a patient's calf muscle for equinus or tightness. It's very common in what we see. It's very common in foot and ankle pathology to recognize the nature of the powerful calf muscle, specifically the gastroc, the outer calf muscle. And it's easy to miss it if you examine the patient quickly and without being a little bit strict to certain details. So for example, The concept of equinus is the role that the gastroc muscle plays in restricting dorsiflexion of the ankle. And so we want to check with the patient's knee in extension, we want to check with the knee in flexion, and compare the differences. So it's very simple to take a patient and simply say, you dorsiflex enough by just pushing hard. But the reality is that this motion is both dorsiflexion and perhaps some eversion or peritalar motion. In essence, you're not really seeing the true role of the gastroc, because this right now looks like she comes easily above neutral, and this is not really the right way to assess it. So here's the right way. So relax the leg, and again, I want you to just let your quad go, and I'm going to hold your knee in extension, but just passively. I'm going to hold your hind foot, and I'm going to kind of lock it in a bit of a neutral, if not a little varus position. And my hand that's doing that is not going to allow you to come around and come up, but really assess dorsiflexion with the knee in extension in a straight line position. So I'm holding her in position, and now I'm going to dorsiflex her and see what degree of dorsiflexion she has with the knee in extension. And then I'm going to flex her knee, which will relax the tension in her gastroc, and see how she does in that circumstance. And if it comes up higher with the knee in flexion, then the gastroc is out of the role here, and there's a tightness of the gastroc if it's stiffer or tighter when the knee is brought back into extension. If both are tight, then it's more likely an Achilles tendon contracture. So I can demonstrate as well the role that this peritalar motion plays, which I think is an important thing to assess. If I hold her locked, as I mentioned before, and I give her a good strong push, you get a sense of where you get stopped. The patient will maybe feel a little bit of calf muscle stretch, some tightness behind the hamstring, calf, back of the knee, perhaps not pain. And then as I do this, if I let go of my hand, the patient can kind of pronate to come up higher. And it's this point that we want to kind of decipher and eliminate or control for when we're truly checking the role of the calf muscle in isolation. The challenge to this exam, this portion of the exam, is that it's pretty subjective. So you try to compare the patient's opposite side. You try to start, as you do more and more examinations of patients, start to kind of build in your own mind a sense of what is the normal amount of tension or how far a person goes. And you try to start to get a feel for what is tightness, because many people have attempted to objectify this measure, and it's proven pretty difficult to do. So it's kind of like calling a strike. Some say it's hard to define a strike in baseball, but an umpire says they know it when they see it. So the next provocative maneuver I think is appropriate to go over is hypermobility. The motion of the base of the first metatarsal to the midfoot is also a common problem that we like to assess for, particularly in its role in hallux valgus or bunion problems. So again, the challenge, hard to objectify. Start to get a feel for it by examining. So I'll ask the patient, I'll often place them on my knee and just again remind them to relax their leg muscles. And I'm going to take my outer hand and I'm going to place it on both the top and the bottom of the second metatarsal. And that's going to be my reference. I'm going to then take my other examining hand and I'm going to place it on the top and the bottom of the first metatarsal. And I'm going to then just sagittally attempt to move up and down the first metatarsal. And this motion is coming from the base of the first metatarsal, what we call the tarsal metatarsal joint. And this is assessing hypermobility of the first ray. And again, examine the opposite side and try to use as a comparison right to left. So again, I'm going to try to grab the top and bottom of the second metatarsal, grab the first with my opposite hand, and try to get a sense of what is normal or increased or tight as a rock. Next issue. It's a perfect opportunity to simply look at the bottom of the foot. Patients often can't see the bottom of their foot, but you want to look for a callus pattern. Patients that tend to have a cavovarus or high arched posture to their foot are going to be patients that are going to be leaning on the outer border of their foot quite frequently. They're often coming in complaining of outer border problems, lateral midfoot pain, perhaps perineal tendon problems, maybe ankle ligament repetitive instability, or sometimes even sesamoiditis because that first metatarsal is bearing too much weight on the ground. So you look for a callus pattern that's concentrated on the outer border of the foot, particularly underneath the fifth metatarsal head. The skin may be thickened here, and that's not just an incidental finding, it's a roadmap. It's basically saying to the examiner, I bear weight preferentially here. Make a note of it, it's important. An alternative pattern commonly seen is the patient that's got a low-lying arch or a relatively flat foot. Our model today happens to have a relatively low-lying arch. And there's often a stripe or a callus beneath the second metatarsal head. So when one notes that, you want to kind of observe that. Observe it in the other side. If there's a difference, one wants to understand why. So these are all important maneuvers. In conclusion, I think that the best way to do a complete physical examination of the ankle and foot is to be regimented and organized in its approach. Again, remember certain principles of that the foot and ankle is part of the weight-bearing extremities, and from that perspective, check the bilaterality of the nature of things, alignment, rotation, length, and then certainly an organized examination, starting with pulses, with sensation, with motor function, with strength testing, and then move into palpation and then your provocative testing, depending upon what you're considering as a more honed down diagnosis. And if you do this regularly and compare opposite sides, it's more and more likely that you'll develop your sense of feel and become a more proficient examiner. Thanks for watching.